So, welcome to this special episode of our podcast. Today, we are honored to host Dr. Nicolas Gélinas-Phaneuf, a respected neurosurgeon who currently practices at CHU de Québec, Hôpital de l'Enfant Jésus. He is also a clinical professor at Université Laval and serves as the director of neurosurgery residency program. So, Dr. Gélinas-Phaneuf's path to neurosurgery began not in medicine, but in engineering. He completed his medical degree at Université de Sherbrooke and his neurosurgery residency at McGill University. And then he did a fellowship training in spinal neurosurgery. So over the year, he became a pillar of surgical excellence and mentorship within the Quebec medical community, known for combining technical mastery and accessibility and integrity. In today's conversation, we'll explore his unique professional path, the reality of neurosurgical training, his philosophy as an educator, and how he continues to adapt in a specialty that never stops evolving. So, Dr. Gélinas-Phaneuf, thank you so much for being part in our today's episode.
Thank you for having me.
So I'll start us off with our first question. Before we dive into the specifics of neurosurgery, we'd like to know more about you as a person. So something that stood out to us was that you began your academic path in engineering before shifting into medicine. Can you tell us a bit more about that transition? What led you from engineering to neurosurgery?
Yeah. Well, the easy answer is I didn't have the good grade enough in Cégep to be a doctor, so I had to have a plan B. And I really love mathematics. I really love physics and problem solving. So engineering was a nice fit for me, and that was late 1990s. So at that time, I would say computers and electronics were becoming more and more mainstream. So I went into electrical engineering at that point in terms of career perspective and interest. And I really loved it. In fact, I strived. I had good grades, and that's why I had the good grades enough to go into medicine afterwards. So that's my path. But I always wanted to be a doctor. In fact, I applied every year until I got in. But it's not time. It's I still learn a lot during my engineering degree, which I did not finish. I'm not an engineer, so I cannot brag about that.
And do you see any similarities between engineering and neurosurgery?
Well, in engineering, it's mostly problem solving, and neurosurgery is a problem solving 101 is try to find the patient's problem and fix it either surgically or not. But the parallels in terms of professions are quite similar, yet obviously there's less mathematics involved and calculations, but overall the idea of problem solving is still quite applicable.
Yeah. And so outside of your clinical work, do you have hobbies that help you recharge or reshift your focus?
Yeah, I think you need to have some form of hobbies, otherwise you cannot just work. Having hobbies to relax is, I would say, mostly reading is the most relaxing one for me. Sci-fi and fantasy to go into totally different universe is my cup of tea, as opposed to human drama on Earth. So I live with that every day. So trying to escape. Yeah, or music, running, doing sports in terms of maintaining your healthy habits is key, because surgery is quite a physical job, being standing up many hours in a day, sometimes leaning forward to operate. So you have to have a good cardiac function and I would say core. So doing workout is quite important. In as much as it's good for your health, it's good for your job as well. It makes it more easier. And spending time with families and friends is also a way to change your mind and not talk about surgery all the time.
And how do you find the time to fit all of that in? Because you must have such a busy schedule as program director.
Yeah, I think, yeah, the key point, and one of the other doctor that came to do a conference at some point in time what was it? Dr. Benzel. Yeah, you know Dr. Benzel. I think he was a Cleveland Clinic. He came
Oh,
to talk to us, and one of his point was never bring work home, and that's what I try to do as much as I can. So when you're in the hospital, clinic, whatever, you cram as much stuff as you can during your day. You do as much as you can. You don't go on your phone and play Farmville or whatever, and you just accomplish as much as you can during your day. So when you clock out, you go home, you do everything else except studying or whatnot. So you can do studying during your day with when you have a time off or so try to those 5-10 minutes intervals you do as much as you can. So during the day you can put out like an hour of stuff before you leave home. So when you get home, you dedicate your time to your friends and families and other interests.
that's really great advice. And one last question for me until we move on to Samia. It was really inspiring to hear that you kind of always wanted to do medicine, even when you were in engineering. But if you were to imagine an alternate life outside of medicine, what would you see yourself doing?
Well, obviously, I would be an engineer. That's I wouldn't
Yeah.
have quit that job. Some of my friends that I met there are engineers and are more like 20 years down the road, and they have they're directors of big companies or things like that. I would have continued on that path, probably space or communication, or because I believe that shooting for the stars is just not a saying, is something that we should actually do as humankind, but and it improves our technology for the future. So I would have probably continued in like aerospace or things like that.
That's great. Thank you so much.
I really love like this mindset of like because I feel like you were inspired also to do like engineering, which is like so much inspiring. And the fact that you chose to do like medicine instead of engineering shows that you really that was medicine what you really wanted, and that's so inspiring to hear. We're just gonna learn like about the process that led you to neurosurgery. So my first question will be like, when did you know that it was neurosurgery that you wanted to do and not anything else?
Yeah, yeah. Going to medicine, I had no clue what I wanted to do. I wanted to be a doctor, but what kind of doctor? Maybe peds or emergency or some things that you see all the time. Neurosurgery is not a job that you see quite often, either in the news or on TV. You see sometimes, but it's not that prevalent. Um, so I would say after doing neurosciences, I think it was a late first or early second year. I really like neurosciences in terms of the idea of localization and problem solving, and it really grabbed my attention. And uh, and then I always in engineering you like to build stuff, and so I was always manual. So neurosurgery was more my cup of tea for on that side. And I approached one of our teacher in Sherbrooke, which is Dr. David Fortin. He's a neurosurgeon oncologist, and I candidly said, "Hey, can I follow you for a day or two?" And he agreed, and I followed him, and I saw what it entails to be a neurosurgeon, and it didn't say it attracted me. So I pursued this avenue. I did some rotation in neurosurgery, and I finally got in at McGill for my residency. But I would say that this, the time spent with a actual neurosurgeon is a good idea to really grasp what neurosurgery is. And this particular doctor is quite approachable. You can have a discussion with him, and it helped to orient oneself if you're not really sure what to do with your life.
Did you hesitate between like neurology and neurosurgery, or it was very clear for you that it was neurosurgery?
was clear for neurosurgery. In fact, I did apply in neurology as a backup plan. In fact, CARMS was not a thing at that time, so it tells my age. So you applied in all the programs you wanted in the French school, and my second interest was actually interventional radiology for doing interventional like aneurysms and so that aspect of neurosurgery that you can do as a neurosurgeon, but you can do as well as an interventional radiologist. So I was actually accepted in radiology, but my first love was neurosurgery, and I don't regret it. Obviously, there's a different lifestyle for radiology and neurosurgery, but I really like my decision.
And did you encounter any doubts or hesitations from your peer or your family when you told them that you're going to do neurosurgery?
Not really. I mean, my whole family is in the health sciences. My mother and sister are nurses. My father is a microbiologist. So I didn't have any problem with them. They just say, do whatever you want. And I knew what it entailed. So yeah, nobody said, don't do this. You're crazy. Some say go in radiology, you get more money, but that's a different story.
Well, thank you so much. That sums up my questions for this section. And yeah, I can see that you're really passionate about neurosurgery, and that's something that really stands out. I feel like from all the people we interviewed right now, people are very passionate about neurosurgery. And if they have like if they were to like redo their CARMs or redo their residency, I feel like they will still do the same path again and again. That's very cool.
Yeah, I mean, it's obvious for obvious reasons. I mean, the path to get where we are right now is difficult. So, and if you go through it and you enjoy what you do, I mean, why would you change anything? It's my advice for young either residents or late medical students is, it's still time to change your mind. It's not when you're PGY 6 almost done that you have a regret. It's easier to change your mind as first off as a medical student, but you can still change your mind as a resident if the product that you see is not what you expected in the end. I think, but if you accept what it entails, then every neurosurgeon I know loves his job. So that's one thing that's common for us.
I can take over the next section. So I'd love to know more about your role as program director. Could you tell us a bit about the most significant changes in residency since your own training?
Yeah. Well, I mean, residency has changed much in terms of program direction. I've been program director for only 1 year, so I'm a junior program director. I've been on the board for like 10 years, but as program director, maybe just 1 year. And throughout that time, what has changed drastically, and you probably know this, is competency by design. So this new approach by the Royal College to evaluate residents through competencies as opposed that from rotations or other stuff has really changed. So we had to change our whole evaluation scheme, curriculum. So the whole program had to change, in fact, to meet the standards of the Royal College. So that was a big transition from 2015 to 2020. I would say that was the transitions. Like last year was the last year we had a resident that was under the old training program. So from now on, every resident is through competency by design, which has good points. With time, the college and us, we see there's some limitations from competency by design. It will probably change with the version 2.0 soon, but that's the major change in training in the last 10 years. And we cannot change every 10 years because the residency is 6 years. So if you change every 10 years your training program, it's difficult to maintain a training program first, and how to evaluate residents is really tough, and not just for the residents, but for the teachers, because now we have to evaluate competencies on different scales, which is different than just, oh, this resident is professional, this resident has good communication skills, and it's more detail, and it's good, but the danger, and that's the main point here, is if you just try to fix for your competencies, you might miss some other opportunities outside of those competencies, and they don't evaluate every aspect of medicine, which is is not just technical stuff, and be able to know things and evaluate patients is more than that. So it will change, but it's a step forward, I think.
Yeah, it's nice to hear that perspective. Is that the EPAs, the entrustable?
Yes.
Yeah. We
It
have
is.
that at McGill. They're making med students do that too now. So
well, I mean, it'll make the transition easier from medical school to residency, and you guys will probably face that as a cohort, because you are a million, like compared to years before. I think next year at Université Laval there'll be 330 medical students, which
oh my
is
gosh.
almost 50% more than like 5 years ago or something. So
Mhm.
just for training opportunities, rotations, it'll be more difficult for universities and teachers to first and evaluate students, because sometimes they'll have 2 weeks with the students, which is, in my opinion, like barely time to see the person. So it'll be a challenge. Sorry.
Thanks for sharing that. And so I know that you've just recently started as the program director, but in the long term, what values do you hope to instill in the residents?
Yeah, well, as program director, you're sort of the head of the teaching program. So in terms of residency, our resident, we want to have them as professional individuals, first of all. Professionalism is a key factor in any medical specialty, but especially in neurosurgery. Having good decision-making skills and gros bon sens, we say in French, which is common sense in English, is also a key value to have. On top of that, personally, I try to have my residents strive not just for competency, but for excellency, expertise, because you'll be in practice for 30 years or something, and you want to improve your skill set throughout your life. End of residency is just the beginning, and to instill that idea in their mind is a key point that a program should do to their residents. So when they finish their residency, they'll have that idea to continue to learn. We have continual medical education credits to obtain as a doctor, but those can be limited. But to have the mindset of continuing to improve your skills is a value that we should promote in our residents. That's for sure. What else? And that's just not as a learner, but as a teacher, to make our resident good teachers, because when they go out in the wild, they'll be teachers to either patients, other residents, nurses in the OR. So to be good teachers is also a key value that residents should develop over time.
That's really great. And just one last question for this section. Talking about like applications, what do you feel makes a residency applicant truly stand out?
Yeah, I mean, to stand out, obviously grades and stuff, but in an interview or letter, what we appreciate is really someone with have high work ethics, meaning they are not just good, but hardworking, willing to to put some effort and sweat in their work, because that's what residency will be. It will be hard work and sweat and long hours. So if you can show to us that you have the capacity and work ethics and work balance as work-life balance, that's a plus. So somebody who has other interests in life and strive in both, sphere of life, that means they can juggle stuff that sometimes are not easy to juggle, and that's a key to a successful neurosurgeon. To be a team player, if you tell me that your letter of recommendation says this guy got into the team, he was like appreciated from day one, he integrated well, that's a plus. I mean, neurosurgery is a team. It's a team effort. You cannot go in a other country and that has no resources just beside yourself and be a neurosurgeon. You need a OR staff, anesthesia, nurses, rehab. You cannot work alone as a neurosurgeon. So to be a team player is a key factor.
Yeah, those are great insights. Thank you. I'll pass the mic to Samia.
Awesome. Thank you, Francesca. So Dr. Gélinas-Phaneuf, as you know, there is like a lot of ideas floating about what neurosurgeons are like. And I just want to take like a moment so we can clear the air. And according to you, like where's the biggest myth about neurosurgeons that you wish more people understood?
A myth. Obviously, one of the biggest myths is neurosurgeons are always working. They have a God complex and they're rich. I mean, that's what you see on TV. Obviously, we're hardworking, but we're not always working. So, hardworking, it is true. God complex, I don't think I've seen a neurosurgeon with a true God complex that you see on TV. In fact, when you have a resident, you try to teach them to be humble and to learn to have a discussion with the patients as opposed to impose your idea on people. So yeah, that's one of the biggest myths, that they are rich and beautiful and get all the women. So I don't know. That's rich. And in Quebec, you're not that rich. You're not poor, but it's not the highest paid specialty, obviously.
Well, thank you so much for clearing the air. My next question is, has your view of what it means to be a neurosurgeon evolved since you started your profession?
Yeah, I mean, when you start, you think you're going to change the world, but the more you go through your residency, you see the limitations of your work and what you can do for patients. And as a resident, you see some terrible injuries or diseases that whatever you do, the patient is not going to fare well. So it's more humbling in that fact that that you cannot do everything. Even if you do everything, it will change nothing. So that's one of the key points that you learn quite early, I would say, in residency, as opposed to this view that I'm going to save a life by opening up his skull. So that has changed. In terms of real life, I mean, and the Quebec situation is not easy. You're a surgeon, but you operate maybe once a week, so you have to do some other stuff the other day. So most of your life is actually spent in clinics or research or education or whatnot. So it is a different viewpoint, because when you're a medical student or a resident, you're mostly in the operating room or emergency or floor. So this is also a different reality as opposed to what you see even as a medical student or resident for real life work.
Awesome. And do you think that the field is becoming more diverse in terms of background, but also in personality type?
I mean, I'm obviously biased because University Laval has the luck to have almost 50% women in terms of staffing for neurosurgery. I think it's the highest in Canada. Mm-hmm. So we're really proud of having almost equal representation. The field of applicant is varied every year. We from different gender, different ethnicities. I would say neurosurgery is still mostly male. That's obvious. It does have a tendency to have more female in the last few years. In terms of my subspecialty, which is spine surgery, that's still a long way to go. It's in Quebec, it's almost 100% male. So that's things we should strive to improve is female representation in our subspecialty. And with the what you call it, the immigration, which is increasing, we have way more diverse candidates applicant. That's for sure.
And Dr. Gélinas-Phaneuf, how accessible do you think mentorship is available to residents compared to medical students?
Well, for medical students, having a mentor is slightly more difficult because you're not yet, your path is not decided. In terms of residency, we do have a mentorship program in our residency program, and I think most residency program have a mentorship available, and that's part of the standards for the college, Royal College. And they are three ways of mentoring a residence. I would say you can mentor them in their early residency to help them ease into the residency and help them cope with the situations and stuff. You can mentor them in research. So we have research mentors who provide research projects to residents. And the third is mentoring for career opportunities and further training. Because as you know, neurosurgery is becoming more and more subspecialized. There are some general neurosurgery spots available, but most of the spots available are subspecialized. So discussing career opportunities with residents and fellowships and other stuff is also a mentorship duty that we do.
And I have one last question for this section. Do you think that we only take 2 candidates in the entire province because neurosurgery is a very hard specialty, or is it just something, or is it just a criteria that is fixed by the government?
Yeah, well, yeah, as you know, we only take 2 residents for the whole 4 programs per year, and that's been going on for I think like 7-8 years. Which is truly a disaster for the future because it takes 6 years minimum plus fellowship, whatever, to produce a active neurosurgeon, and our mean age is around 50. So, within 10-15 years, there'll be a big retirement proportion of the neurosurgeon, and they won't have replacement. The main reason is in terms of job opportunities, because you cannot just go and say I want to work at this hospital and please hire me. You need OR staff, you need OR tables, radiology, physiotherapy, occupational therapy. So you cannot be a neurosurgeon by yourself in a center. So it entails cost, and the government has no money, so they won't expand this field. So if there's no job at the end, it's difficult to justify, the formation of more, the education of more residents. Although if you take, numbers, there'll be some gaps like down the road. For right now, the market is quite saturated, though.
Well, thank you so much, Dr. Gélinas-Phaneuf.
So for the next section, we wanted to talk a little bit about the evolution of neurosurgery. It's obviously a field in constant evolution. From your perspective, what have been the most significant clinical or technological shifts in the recent years?
Yeah, I mean, I started my residency in 2005, so that's 20 years ago. And in spine surgery, which is my domain, it has almost 180 degrees change since that time. We have navigation technologies for screws, which did not exist at the beginning. We have, MIS, minimally invasive surgery, endoscopy, robotics is down the road. We have interbody fusion, which I used to do twice a year while resident, and I do twice a week now. So it's a different ball game from years ago. In terms of cranial surgery, a lot of is on the technical side has changed in terms of navigation, in terms of adjunct to surgery, either monitoring or radiology or chemical reaction to produce colors to see on tumors. Awake surgery has progressed as well. So it's an ever evolving field, which is exciting because you don't want to be in a dying field, you want to be in an evolving field. But yeah, it's fun to be part of that transition.
Yeah. And what do you think neurosurgery will look like in 10 or 20 years from now?
Yeah. To be honest, I think neurosurgery will split. Okay, spine surgery and neurosurgery will divorce, because spine surgery in and out of itself is getting more and more, its own thing. It incorporates orthopedic stuff, neurosurgery stuff. So it will be difficult to be a good spine surgeon at the end of a regular residency, and making a proper spine surgery residency will be will probably happen down maybe 10 years from now. So neurosurgery will remain on its own, but it will change I think it will change the field a lot, because 60+% of procedures in neurosurgery are spine procedures. So that leaves only 40% of cranial procedures. So that's not so the number of neurosurgeon required for this small subset of cranial procedure will be less.
Yeah, that's really interesting. And just another question relating to spine. Could you tell us a bit about the difference between like orthopedic spine surgery and neurosurgery spine surgery?
Yeah, that's always a debate we have at the last conference we had in Quebec last spring. It's more and more difficult to differentiate. Obviously, intradural pathologies like tumors or vascular malformations are only doable by neurosurgeon, because we have the expertise to open up the duro and close it. But that's about it. I do scoliosis surgery. I put as much screws as my orthopedic colleagues. So I don't see my work as different. And in fact, we have our own clinic, which is a spine clinic with ortho and neurosurgery. So we have no difference now. So the lines are being more and more blurred.
Yeah, I've always wondered about that too. But it's cool that you were saying that they might merge together at one point. That would be interesting to see.
Well, I mean, technically,
Yeah.
we are merged as a service. In the hospital, we have, our beds, our OR time is spine surgery. It's not official, but it's the way we work. So at some point, this will become official. But
Yeah.
neurosurgery is so different, but it's the same, but it's different. It's so it's interesting developing.
And one last question for my section. How do you personally keep your knowledge up to date with all the changes that keep happening?
Yeah. Well, the obvious answer is journal articles and conferences. That's easy. I personally am also on the board of directors of the ANCQ, which is the Association des Neurochirurgiens du Québec. And actually, I'm the director of continuing medical education. So I'm the one with my colleagues that's responsible to organize the conference every year. So in that work, I had to find what's going on, new research and topics to discuss. So that's how I do it. And then that job also entails how to provide opportunities for practicing neurosurgeon to maintain that new knowledge and obtain that new knowledge in different means, either conferences, webinars, or practical laboratory stuff. So that's how we do it in real life. The obvious answer is, if you really, really, really want to learn a complex new procedure, you can always do like a mini fellowship, like 3-6 months. Even as a practicing neurosurgeon, you can go 6 months, learn endoscopy, and come back. That's doable. It is tough to organize in terms of workplace and other stuff, but if it's something that you really want to pursue, that's doable.
That's great. Thank you so much. I'll let Samia take over the next section.
Perfect. So now we're at our last section. So Dr. Gélinas-Phaneuf, you play a major role in shaping tomorrow's neurosurgeon. So my first question will be, is there a particular moment or student that reminded you why teaching is important?
Yeah, recently, because you think you learn all the time, but we had a fellow, and he finished the case, and he talked to me afterwards, like, I learned stuff today, even though he did like 6 years of neurosurgery, 1 year of fellowship, or he still learns as a fellow. And to me, that means the world, because to continue to learn as you go in your training is a must, and to be able to provide that to students or fellows is quite important. The other moment that really warms my heart is when a nurse comes to me and say, I really appreciate how you teach a resident and us, because we are part of the team when you do that. Okay, so they're not dismissed; they are part of the team. You teach them, anatomy, and sometimes it's really basic stuff, but just that they feel part of a real team effort. And in the end, it's better for the work environment, and a very egotistical. It makes your job easier because they're better. So as much as you can teach them, it will make your life easier, and the patient will appreciate that down the road. So that's
I completely agree with you. And how do you make med students who shadow you more included in the operating room?
Med students, yeah. So again, the med students are a particular breed of people. They come to the OR. Some are really interested. Some are there because they were forced to do this rotation. So you have to know your audience beforehand. So if somebody, candidly tells me, hey, I want to go in neurosurgery, then obviously my attitude would change towards them, as opposed to somebody who says, I match in psychiatry, I'm just there to do my rotation because that's something I need to do. So, but the basic stuff that the medical students like to see is, I like to show them the anatomy once it's open, and show them anatomy. They also like easy stuff is closure with sutures. So they really appreciate when I let them do this. But overall, it's difficult for medical students because we see them like 2 days in 3 weeks. Sometimes out of the blue they appear in our operating room, and it's a difficult situation for them, because it's you have to prove that you're interested in like 5 minutes.
Mm-hmm.
It's really hard.
And how has your experience as an educator changed by the way you approached your own practice?
Sorry. It draws back to my my answer before, and teaching others is the way to improve. First of all, your own practice, because you will learn as you teach. to help patient population and outcomes, the better your trained neurosurgeons will be, the better your outcomes in your population, the better your society will be. So it's a means to an end that it's difficult to separate from just being a surgeon.
Awesome. And do you feel that mentorship today looks different from when you were in training, or is it kind of the same?
Yeah, well, as we discussed, the competency by design has really changed the field. So mentorship in terms of competency is different as mentorship before. Okay, so now a mentor has to look at what your competencies are actually, what have you done, what remains to be done, and a mentor can help you figure out what competency to do and when. So let's say you do a rotation in vascular surgery. Well, it's the good opportunity to ask for that particular competency on brain aneurysm. Okay, don't try to do a brain aneurysm on your spine rotation. So it can help you cue and target your competencies, and sometimes it's just a tap on the back, hey, you're doing great, or sometimes it's sit down, maybe you should do more competencies in your next rotation, because otherwise you'll be lagging behind. So that's the way we do mentorship now with competencies, as opposed to before, where there was less. The competency is nice because it gives targets. It gives like, okay, particular this point, you can have you can do 3 more of this procedure with and then you will pass. We didn't have that before, so it has changed.
And for my last question, what would you say to a med student who really want to do neurosurgery, but he's dealing with imposter syndrome?
Imposter, oh, yeah. Well, okay. So first of all, the imposter syndrome is, personally, I think, is a myth. If you have the capacity and the interest of doing some stuff, you can do it. Nobody, you yourself will feel the imposter, but I don't think the society will say that you're the imposter. It's a personal feeling. Yeah, I wouldn't discourage anybody in doing neurosurgery if they have imposter syndrome. In fact, imposter syndrome can be a mean to say that you have a good metacognition, saying that you recognize maybe your limits and say, oh, I have so much limit, why should I be a neurosurgeon? Well, everybody has limit. Okay, so that's true. That's a truism. Everybody has limits. Knowing your limit is actually probably, when I go back to that question, knowing your limit is probably the best thing a neurosurgeon can have, because it affects everything in your life, either your decision-making skills, your surgical skills, your outcomes. If you do stuff that's way over your pay grade, it's knowing your limit is a key point. And imposter syndrome is sort of a nice way of saying I have limits, I know my limits, and because I know my limits, my peers might say I'm not as a good neurosurgeon, but in fact, you probably are the best.
Well, thank you so much for those words. I think it's going to help a lot of people who will be listening to this podcast. Because I feel like when we think about neurosurgery, as we mentioned before, it's a very demanding specialty, and a lot of people who are genuinely interested into this specialty, they think they are not good enough. So I really hope that after listening to your advice, they will like believe in themselves and keep trying.
Yeah, because and as a neurosurgeon, some say it's a very technical specialty, but technical skills are stuff that you can learn as you go. You obviously, if you have 5 tons, that's different, but you can learn to do most of the technical skills throughout your residency. That's no problem. What you cannot learn is your limit and how to be a team player. That's tough to really learn. You really have to almost have that beforehand. Otherwise, it will be difficult in your residency. But just technical skills and the long hours, don't worry. It's not. not that bad.
Thank you so much. That makes the end of this section. So Francesca, you can. I'm passing you the mic.
Yeah, so that concludes our podcast for today. Thank you so much for taking the time. I mean, we learned so much, and you're truly a leader in your field, and it shows through all of the leadership positions you hold and how you value teaching and just taking the time today to share your insights with us. It really means a lot. So thank you. We really appreciate it.
Thank you. I appreciate your interest.
And we know how much like you're busy, but thank you so much. Like it means a lot for us.
That's another myth. We're busy, but not that busy. You know, we have some, you know, as staff, we have a bit of time off. You know, it's not as crazy as it sounds, but it is busy, but it's not. It's less than a resident. That's obvious.
Mm-hmm.
All right.
Thank you.
Take care.
Have a nice
Okay?
day.
Bye.